All right. Well, thank you. Thank you very much for inviting me to speak. And I'm very sorry I can't be there in person. I'd much rather be in sunny Orlando than freezing cold Perth. But thank you very much for joining the session, both virtually and in person. And my name is Merrilee Needham. I'm a neurologist from Perth, Australia, and I've been asked to speak today on the patient journey from diagnosis to clinical management. So what I'm going to cover today is I'm going to start with, what happens at the diagnosis, talk a bit about information and where to get it, talk a little bit about patient education, going to talk a little bit about non-medical therapies, and then I'm going to switch to medical therapies at the end. So I don't need to probably tell this audience what happens to you when you get a diagnosis of myositis, but I think the common things that I see is that you ask lots of questions. Why have I got this disease? What can I do about it? What treatments are available? Will I get better? Will I get worse? Are my children or family at risk? And many, many more questions. So the first step, I think, when you get a diagnosis really is to understand as much of the disease as possible. And I think the very first appointment is really, I think you only really absorb about 10 to 20% of what your specialist tells you. So hopefully they give you some references or materials to read and point you in the direction that once you've got over the shock of being told that you've got a diagnosis or a disease and what it might mean to you, you can start to educate yourself around what it really means to you and your family. So I find I point my patients in the direction of useful or reliable information. I think your specialist should be a very good source for you. I think the TMA has absolutely extended itself with regards to the resources and the information it provides to patients. And the other patient association websites, including the one in Australia, is really helpful. I point my patients to both those sites. Now, with the internet, I think it's really important that you only read reputable sites. So university sites, patient association sites. Initially, especially, please avoid blogs. Not everyone who blogs actually has the disease. That might shock some of you, but there's a lot of misinformation out there. The clinicaltrials.gov, I tend to point my patients to in terms of finding out more information about current clinical trials. And of course, mixing with other patients, I think, is always really helpful from people who have walked the journey before you. So in terms of useful sites, I think PubMed has some really fantastic papers that you can access if you're so inclined. It's a US-based database for scientific publications. So if you have a bit of a scientific or medical bend, you might want to go on there and do specific searches for what you're really interested in exploring. As I said, the clinical trials website, I point my patients to and ask them to keep an eye on it because almost all clinical trials, both in the US and outside, are registered on this website. And finally, Twitter actually is a source of abundant of information. Not all of it is accurate, but it's a great way to stay up to date with myositis information. And many research groups use it to share information very quickly in publications. And because the myositis community, even internationally, is quite small, we all sort of like and share and follow each other. So we tend to hear about latest breakthroughs pretty quickly. But of course, with the internet, it's always tricky to know how to spot fake news. So I think the caveats to be really careful of when you are looking at the internet for information is to be aware that it's a repository for anything and everything. So not everything on there is written by reputable people who have knowledge. And I think it's also important to point out that personal experience does not equate to science or evidence. So a lot of people out there have stories, not all of them are true. And just because it works for one person doesn't mean that it's necessarily going to work for another. So if there's any doubt about what you read, please check the source, ask lots of questions, be a bit skeptical, and talk to your doctors and healthcare team about which bits are good and which bits might have questions. And these two conversation articles that I've got the links to on this slide, I think are really helpful. And I do get my patients that come in with loads of papers and articles to talk about with me. I get them to read these to really help to spot bogus science or fake news, if you like, because I think there's almost too much information out there, and sometimes it's really hard to sift through what's useful information and what's not. So the first appointment, as I said, is just a general overview and pointing towards good information. But the second appointment, you should come armed with lists of questions for your specialists. So after you've done some of your own reading and some of your own exploration and talking to other people, really try to understand as much as you can, because education and information is a journey. It doesn't stop just after diagnosis. It's an ongoing communication between your clinician and your family, because different information will hit you at different times. Different information is relevant at different times. And information is constantly progressing because of all yours and the TMAs and other patient associations' drive to fundraise and support research. We are progressing things faster and faster because of all of your efforts. And so there's new diagnostic techniques, new understanding of the antibodies, new, more specific therapies than have ever been available before for patients with myositis. And over time, your interest in clinical trials may change too. So I think it's super important to really just stay on top of all of this and keep the conversation going with your clinician over time. So what's my approach to therapy? Well, I'm just going to start first with non-medical therapy. And the reason to do this is because the mechanisms of muscle loss in myositis are really complex. So there's immune-based mechanisms which respond to immunotherapy, but there's a whole array of non-immune mechanisms that are important in all forms of myositis, not just IBM. And unless you treat both the immune and the non-immune mechanisms, we're probably only really getting halfway to treating you. And in terms of the muscle fiber destruction and the impaired ability of the muscle to regenerate, if we attack both pathways simultaneously, we're much more likely to get a really positive outcome and better quality of life for our patients. So when we look at the treatment of myositis, it has to be multimodal. There's not just a one size fits all, and it's not just about immunosuppression. Immunosuppression is a very important part of treating myositis. But as I said, we need to treat the non-immune aspects such as the mitochondrial dysfunction, which are the battery of the muscle cell. We need to really look at muscle regeneration. Once you've lost muscle, how do we get it back? And of course, we need to treat the whole patient, your mind, your home environment, look at your relationships and your lifestyle factors that all play a role in your quality of life. So with my patients, I often draw this diagram for them, and I talk to them a lot about the physical battle that they're undergoing and about controlling the things that they have some element of control over. We can't control the diseases that we get, but we can control how we respond to them and the things that we ourselves can drive. And some of those things include our diet, what we eat, our headspace, our sleep, our exercise. And sitting outside of this, of course, are symptoms like pain that influences all of these things. So I hate to break it to you, but if you don't like exercise, you're not going to like this talk, because exercise treats all facets. It treats the immune activation, the non-immune aspects, and it's a very important part of treating the whole patient. It is good for everything. It is anti-inflammatory. It reduces the cytokines. It increases your regulatory T cells that are very important in autoimmune diseases. It suppresses fibrosis and scarring, and it shifts your muscle metabolism towards much more energy efficient ways of producing energy for your muscles and reducing that mitochondrial dysfunction that we see, particularly in IBM, but also other forms of myositis. And as I said, the mitochondria are the battery of the muscle cell. So you want to be functioning on energizers and Duracells, not no-frills batteries. In addition, exercise is really important for promoting muscle regeneration. So a lot of the immune-based therapies stop the destruction of the muscle. But if you actually want to improve and get stronger, the only thing that really does that at the moment is exercise. So exercise is absolutely 100% proven in myositis. It is a standard of care. It's not experimental. It is a standard of care in myositis. It has to be individualized. Everybody's different, and what they can do at different phases of the disease is different. And I believe you've got to have a combination of aerobic-based exercise, which is like the walking or the swimming, something that gets your heart rate going a little bit, but as well as resistance-based exercise. You need a little bit of light resistance to really build that muscle strength and function. And I know Helene Alexanderson, I think she's going to come to Orlando and is speaking. So hopefully you'll get the opportunity to meet her, because she's a world leader in this area. Exercise has been proven to improve strength, function, and quality of life in patients suffering all forms of myositis. So every time my patients see me, they know they're going to get a lecture on how much exercise they've been doing and how we can tweak it a little bit further and a little bit further. A little bit at a time is the key. But if we just treat the physical body, we're missing out on half the patient because the mind-body interaction is really strong. And I talk to my patients about this quite a lot. So I think we underestimate and perhaps even underemphasize sometimes the psychological impact of living with a disease that often causes progressive disability or affects quality of life. And actually, chronic diseases like these are associated with very high levels of depression and anxiety. And at the moment, there's no proven interventions in patients with myositis, but that's only because there haven't been any studies done. There's been a survey that was put out in Japan not too long ago, and they found that 73% of their myositis patients with IBM describe psychological and the mental aspects of the disease, one of the most challenging aspects of the disease. And Michael Rose determined in IBM that psychological interventions may help improve quality of life in IBM, even if the disease itself can't be treated. And I'm a big believer in that, and I definitely see that in my own patients. So I talk to them about psychological techniques like mindfulness, which is the concept of being sort of fully in the present at that time, trying not to spend too much mind time grieving for the past body you've left behind or being fearful of the future. Those things and those thoughts have a role, but they can't take over from today when there's still a lot of today left to live. And I talk to them a lot about acceptance commitment therapies, about sort of coming to terms with a new normal. And I think that's a really important strategy that helps some patients as well. But as I said, one size doesn't fit all. So I think seeing a really good clinical psychologist, perhaps that has an expertise in living better with chronic disease and disability, can be very helpful. I think it's also important to address the fact that relationships can change when one partner is suffering a chronic disease that affects their quality of life and their ability to be independent. There's a couple of quotes that I think are quite pertinent. Chronic illness can often shift the balance of a relationship. The more responsibilities the one partner takes on, the greater the imbalance. And if you're providing care, you can start to feel overwhelmed and even resentful. If you're the one receiving care, you can feel more like a patient than a partner. So there's some very good websites that deal with this. And again, sometimes seeing a relationship counselor can be very powerful in terms of just having a third party present to really openly discuss this with your partner and try to come to a place where you're both comfortable. I also encourage my patients to set up their home environment to make life as easy as possible with day-to-day living, because there's nothing worse than being faced all day, every day with the things that you can't do. It makes it very frustrating for patients to live day in, day out, constantly trying to do things that they're really struggling to do. So it makes it much better to set up your home so you can keep doing everything that you want to be doing, albeit in a different way. We recently did a survey of Australian myositis patients with the help of the Myositis Association of Australia, and of which the vast majority that answered the survey were IBM patients, nearly 80%. And quite a lot were over 60, so about nearly 90% were over the age of 60. Interestingly, that devices that related to bathroom use and mobility were the most owned and the most used, but not considered the most useful by patients. And what was considered that scored the highest and most useful was modified driving, but these were the least used devices. Bed and chair risers and modified beds also scored quite highly. Not surprisingly, the number of devices increased with the number of years you'd had a disease, and also the number of devices was associated with increased costs for the patients and their families. What about diet and sleep? Well, not surprisingly, again, there haven't been really any studies performed, as far as I know, in myositis looking at different diets, but I have a lot of patients that pursue different diets, antioxidant diets, anti-inflammatory diets, and I found a single case report of a ketogenic diet with positive effects in IBM. But I do think it's sensible to eat everything in moderation, eat a well-balanced diet. That's what the body's really set up for. definitely with sufficient protein. Protein is the building blocks of muscle. So you definitely want to be eating sufficient protein in your diet. And that's from things like meat, fish, cheese, yogurt, nuts, grains, as long as you can swallow the nuts and grains. Sleep is really important. Chronic sleep deprivation is seriously the worst form of torture. I'm a mother of twins, and I can tell you I didn't sleep for a year after they were born. Sleep deprivation makes everything much more difficult. And in IBM in particular, but all forms of myositis, sleep-disordered breathing is very common, even up to over 80%. So I suggest all clinicians screen all their patients at each visit for symptoms of excessive daytime somnolence. What that means is that if you're sitting around and not stimulated, that you're nodding off to sleep or falling off to sleep easily in front of a boring TV show or, at the dinner table, even worse, behind the wheel of a car. And that obviously can be extremely dangerous. So I have a very low threshold for performing sleep studies and intervening with non-invasive ventilation in my myositis patients, especially those with bulbar weakness. That is the muscles of swallowing up here in the throat. And that's because that's got a very high prevalence of sleep disordered breathing if those muscles are involved. And non-invasive ventilation is a bit like CPAP. So that's a small mask that you put on your nose or nose and mouth that just blows a gentle pressure of air in to splint that airway open, to let the oxygen in and let the carbon dioxide out. And it makes a significant difference to quality of life in patients. Forward planning, I think, is really important to talk through with your specialist. And obviously, no doctor has a crystal ball, or our job would be very much easier. But it's always worth asking clinicians based on their experience with other patients. What can I expect in 5 years? What can I expect in 10 years? Will I ever get off treatment? Will I get worse? Will I be able to walk without a stick? And I think it's good to ask your physician to be really honest with you, because talking about it doesn't mean it's going to happen. It just means that you can plan for the worst. That doesn't mean you stop hoping for the best. So I think it's really smart to get in and plan in advance. Things like life and partner priorities, make sure that if things are definitely going to get worse, at least for the foreseeable future, that if there's things like climbing Mount Everest you want to do, you probably should do them sooner than later. Talking about work and finances, at what point do you start thinking about giving up work? How are you going to manage financially from there on? And talking about your home and support mechanisms. So these are all things that are easier to do with forward planning and much more difficult to do when emergencies arise. So how do we treat it? So I think it's really important that we all understand that, and I'm sure everyone in this audience understands, that we really are starting to split myositis into lots of different groups. So in the 1960s and 70s, we talked a lot about just polymyositis and dermatomyositis. And in the last couple of decades, we've split out IBM. We're increasingly recognizing necrotizing myopathies and this big group of anti-synthetase antibodies and overlap myositis group that have systemic involvement with lungs and other organs. And I think it's important that we're splitting them up and understanding the differences between each of the diseases, because it has a significant impact on the medical therapies we use, because the disease processes in each of these diseases is different. And if we attack this specific disease process with a very specific treatment, then it's much more likely to be effective. So that's why I think over time we're starting to understand these diseases more, we're splitting them up more, and that's going to really help us treat each of these disease subtypes much more effectively in the current and near future. So as I said, why are we subclassifying myositis? Well, I think it's because we're increasingly beginning to understand the molecular pathways of the disease, which means we can target therapy far more precisely. And I think this is a very important, in fact, a vital step for more effective therapies than we've currently got. So if we just start by having a look at immune-mediated necrotizing myopathy, or necrotizing autoimmune myopathy, I'll call it NAM for short, if that's okay, because it's a bit of a mouthful. This is an antibody-mediated immune disease, and this immune disease destroys muscle fibers, but the inflammation that's caused by all these antibodies and activation of the immune system also impairs the muscle's ability to regenerate. So patients often present with not only weakness of the muscle, but even at first presentation, there's often wasting of the muscle. It's smaller than it should be. and it mainly affects shoulders and hip muscles as well as thighs. We know from a lot of case series that have been published over the last little while, early aggressive therapy can turn off the muscle destruction and allow the muscle to slowly heal. So we know the antibodies that are highly associated with this form of myositis are the HMGCR antibodies and the SRP antibodies, but there is a whole group of NAM patients that have antibody unknown, if you like, a form of disease, and that's probably just because we haven't identified the antibody yet. Now, Olivier Benveniste and Yves Allenbach published this review on NAM in December 2020, and it's a beautiful paper written about not necrotizing myopathy. And it talks through the disease process as we understand it at the moment, with these antibodies leading to inflammation here that destroys the muscle fiber, but also how the inflammation impairs the muscle's ability to regenerate at the same time. So in this paper, they proposed a suggested approach to therapy, and I think most people in the world would follow this. And it's usually, in most parts of the world, a combination of steroids and a steroid-sparing agent like methotrexate. And if the disease is quite fulminant, I think starting with IVIG right up front is really effective. Sometimes we even have to hit with rituximab. And then this keeps going on as the steroid dose hopefully falls over time, and we may or may not have to maintain them on IVIG. So to summarize necrotizing myopathy, a large proportion produce autoantibodies, but there's probably a group of antibody unknown that we're yet to discover. These antibodies target the muscle cells, causing muscle fiber destruction, but preventing them from repairing. Patients, as you know, present with weakness and muscle shrinkage, but early aggressive therapy can turn off that destruction as quickly as possible and allow the muscles to recover with exercise. The longer you leave treatment or the slower the treatment start, often the worse long-term outcome. Now, it's really interesting. I'm just going to take a sideways step here because some of my patients say to me, well, why do you treat NAM like this? And why does my doctor give me this? Or why does your doctor give you that and I'm given this? And I think it's important to recognize, particularly in different regions of the world, access to different care is different. There's different medical systems all around the world. And although we have suggested treatments, these aren't mandated or necessarily proven to be the best. It's just what a lot of experts in the world are currently using. So what you're prescribed is influenced not only by your access to these treatments, the cost of the treatments, but factors within you about what other diseases you have, what other drugs you're on that might or might not interact with these, and also your own doctor's experience with these drugs. If your doctor's got a lot of experience with methotrexate and a lot less with azathioprine, for example, they might choose to put most of their patients in the first instance on methotrexate. And certainly I would choose methotrexate over azathioprine in Australia because we have a very big issue with skin cancer in Australia. So I tend to see a lot less skin cancer long-term with methotrexate than with azathioprine, but that's just my own experience, not because one drug is necessarily better than another. So there's lots of reasons why, and especially at these patient conferences when you're exchanging stories, why some patients might be on some treatment and others are on other treatment. So switching tack to dermatomyositis, as most of you know, it's what we call a microvasculopathy. So it's a problem really with the small blood vessels in your muscles. And what that does is it basically causes small strokes of your muscle. The muscle fibers don't get enough oxygen and they can die. And that's one of the mechanisms that's thought to lead to the muscle loss and weakness in DM. It's a lot more complicated than that, in fact, as we've understood this disease. And I'm going to get to that in the next slide. So patients often present with quite an acute, it can be over weeks, or subacute over weeks to months of hip and shoulder weakness. And in dermatomyositis, typically it's associated with skin involvement, with rashes over the palms or the face. So the heliotrope rash here around the eyes, or this rash on the cheeks over the extensor surfaces, like with calcinosis over the elbow like this, nail fold changes, and these Gottron's papules here over the knuckles. But as we're delving into the molecular pathways of these diseases, What we've found, and this slide is courtesy of Professor Steve Greenberg, who's been a real leader in this area in all forms of myositis, but particularly DM and IBM, has found that it's really a type 1 interferonopathy, and that this pathway, you can see the activation in DM compared to all other forms of myositis. What does that mean, and why is that important? Well, I think it's because the implication of finding this pathway means that if we can block the type 1 interferons with medicines, then maybe we can turn the disease process off. So instead of blasting the entire immune system with drugs like corticosteroids and methotrexate, we can actually just target a small branch of the immune system, which has potentially a lot less side effects on the rest of your immune system, but can target the one bit of it that's causing this disease. Now, the JAK is part of the type 1 receptor that receives this interferon. So not only are we looking at molecules that directly block the interferon, but we can also block the receptor where the interferon works. And the group out of Hopkins, led by Lisa Christopher Stein, published this nice study again just a couple of years ago looking at tofacitinib in refractory dermatomyositis with some very encouraging results. So over the last couple of years, a lot of DM patients are being started on these JAK inhibitor medicines all around the world with quite good success so far. The general approach, I think, to these forms of myositis has always been traditionally corticosteroids at high dose initially with a taper, with a steroid-sparing agent, methotrexate or azathioprine, mycophenolate. If you're not really responding to that combination, I think the first step is to make sure the diagnosis is correct. And then we add on other therapies like IVIG or rituximab, or we add in a second agent to the methotrexate like cyclosporin or tacrolimus. And then third line, we tend to use the biological therapies. But this over time is slowly changing. So some of these biological therapies are really coming up into second line therapies. And probably at some point they'll come up into first line therapies, and hopefully we'll get rid of the high dose steroid at some point too. What about IBM? So IBM, as you all know, is a slightly different form of myositis to the DMs and the NAMs. It's different because it not only has inflammation where you've got the immune cells or the lymphocytes surrounding and even invading muscle fibers, but you also have the degenerative changes of protein deposition in the muscle, these rim vacuoles, and as well you get these mitochondrial changes where the battery of the muscle cell just isn't functioning properly, seen here by those purple cells inside that biopsy. Now, if we look at what we think is the molecular pathway of IBM, it's extremely complex, and I'm not even going to talk through this slide except to say that we're really not sure yet of exactly what leads to what to cause what, but almost certainly all of these factors are contributing to muscle loss and vulnerability in inclusion body myositis. So not only do we have very significant inflammation, but we also have cell stress with endoplasmic reticulum stress, mitochondrial stress, that over time is leading to protein deposition in the muscle and the cell just failing over time. And this is on an aging background. So IBM really only occurs in people over 40, very rarely prior to that. And certainly it's not a young person's disease at all. So how do we treat a disease that is so complex? Well, if we break it up, we can look at focusing just by treating the muscle wasting and the atrophy. And I'm going to talk to you a bit about the studies that have been done so far, looking at bimagrumab and follistatin. But we've also looked at oxandrolone, and our group has recently looked at testosterone and, of course, exercise to treat the muscle wasting and the atrophy. We can look at treating the muscle inflammation, and I'm going to talk to you about a couple of current trials, the anti-KLRG1 antibody as well as the sirolimus trial. But we know there's been at least 10 or 12 other previous trials of immunosuppression, none of which have yet shown to long-term benefits. We can focus on trying to get the muscle cells to metabolize and clear these excess proteins better. And that's where arimoclomol really functioned. And unfortunately, that was another negative study, which we'll look at again. But sirolimus also has a role in this arm. And finally, we can look at trying to treat the mitochondrial changes. And again, really that therapy is quite empiric with coenzyme Q10 and mitochondrial type supplements, as well as exercise therapies. So if we're going to start first in IBM, looking at the non-immune aspects, we are looking at muscle building drugs, and these work best in the presence of exercise. So if we look at what we've done so far, there's been two major directions of research in IBM. One is the bimagrumab study, which I'm just going to take you through. It's a bit of an older study now. And then Jerry Mendel's been leading work looking at the follistatin gene and looking to see if it can improve muscle strength and function in IBM patients. So just to turn our attention a little bit to bimagrumab, bimagrumab was a monoclonal antibody that was directed here against this activin 2B receptor. And what this receptor normally binds is myostatin and myostatin-like proteins. So what myostatin does is it stops muscle growth. So what this antibody did was it stopped the stopping of the muscle growth and allowed unregulated muscle growth. And these pictures are what is currently in use to get double muscled cattle, double muscled whippets. And this poor child was born with a mutation in the myostatin gene and had unregulated muscle growth as a result of not being able to stop. So normally if you damage a muscle, your body sets up this process to repair the muscle and regrow the muscle, but it has a stopping mechanism inbuilt, so it doesn't just keep on growing without any control. So what bimagrumab doing was getting rid of that control mechanism that we all have. And what you can see from some of these graphs, if you focus particularly on the blue and the red lines, the blue is the highest dose, the 10 milligram dose, and the red is the second highest dose, is if we look at this outcome, the inclusion body myositis functional assessment, or the CIFA, it definitely seemed to have a long benefit, even up to a year. It was still sitting slightly above baseline and only just dipped below the baseline measure at week 68 in comparison with the other groups. And that's just graphing the same graphs, but in a different way. But you can clearly see there's a dose response to the bimagrumab. You can also see when we looked at DEXA scans at the lean body mass. So this drug absolutely grows muscle. What we didn't prove, though, is that growth in muscle having any functional effect as measured by the 6-minute walk test in our IBM patients. So you can see, unfortunately, that the data is quite messy. And for those of you who have done 6-minute walk tests, know how problematic they can be. If you're feeling a bit tired or you've had a fall in the week before and you're a bit sore, you're going to generally walk less. So the data is really hard to interpret. And really, drug companies and governments want to invest in drugs that are going to make life better and make function better and quality of life better, but they're not just going to invest in drugs that just grow muscle with no functional, outcome. And we didn't prove that in this study. What about arimoclomol? If we look at drugs that focus on helping your body get rid of excess protein, and unfortunately, this study led by Professor Dimachky and funded by Orphazyme announced the top-line results in the last sort of 6 to 8 months or so. Arimoclomol targets the heat shock proteins within the muscle to really help the muscle cell get rid of excess abnormal proteins. It was a very big and well-designed study, 150 patients from 12 sites in the US and the UK, and compared 400 milligrams of arimoclomol 3 times a day versus placebo for 20 months. So it had a long duration, which we need in IBM studies, and a reasonable dose of drug. But unfortunately, it failed again to reach the primary endpoint as measured by disease progression measured by the IBM functional rating scale. So a different scale to the one used in bimagrumab, IBM FRS, this one. What about treatments to address the inflammatory aspects of IBM? Well, I think many of you know who this is. This is Professor Steve Greenberg. And really, this was his brainchild. So he has developed this drug that is an antibody against this receptor called the KLRG1 receptor. Now, this receptor sits on the terminally differentiated T cells that he's shown invade the muscle fibers in IBM. So these ones are marked by the brown stain here, and you can see that these are the ones really invading the muscle in IBM. So what this medicine does is it targets that marker on the cell surface of these very cytotoxic or toxic cells that we think are destroying the muscle, and allows your body to mark them and destroy them. So it's in very early phase clinical trial at the moment. So a phase 1 study is all about safety. Is this drug safe to give humans? And so that's where this medicine is at the moment. And that phase 1 study is happening in Australia. But I understand phase 2 studies are being planned. What about sirolimus? Well, this was Olivier Benvenist's brainchild. So Professor Benveniste is an immunologist in Paris, and I believe he's also currently in Orlando. And he tried this treatment called sirolimus in 44 patients in Paris. 22 were on treatment versus 22 on placebo, and found some very highly suggestive results that the sirolimus may well slow down the progression of disease. So he thought to try this because sirolimus actually has quite a unique mechanism of action compared to all the other immunosuppressants we've tried so far in IBM. It not only affects the effector T cells, the ones that are killing things, it preserves the regulatory T cells, the ones that we need to help balance the immune system against autoimmunity. But sirolimus has a second action. It's an mTOR inhibitor, so it helps to induce what we call autophagy, which is eating proteins or protein degradation. So it not only will reduce the inflammation, but hopefully will help the cells clear the excess protein simultaneously to help maintain patient function and independence for longer. So we've designed a phase 3 study across the world that's really based on Professor Benvenist's initial trial design. It's a double-blinded, randomized controlled trial of sirolimus again versus placebo. But this time, instead of doing it in one center, we're doing it in 14 centers across the world, with a couple of sites in the US, 1 in the UK, 4 in Europe, and 7 in Australia. We're allocating the 1-to-1, so 70 patients on drug versus 70 patients on placebo. What are we aiming to measure in this to see if we can measure a change in the trajectory of patients' disease? We're using the IBM-FRS, so the same outcome measure that arimoclomol used. And to talk about clinical trial design and outcome measures is another whole talk in itself. But this was the one that the world experts agreed was the one that was most likely to be accepted by everybody around the world as making a difference in patients' lives. But we are measuring a heap of secondary outcomes to at least get a signal on these other measures in case we miss it with the IBM-FRS, whether there's a signal in any of these others that it might be doing anything good for the disease. We do have some exploratory outcomes. We're looking particularly at different, whether you have the antibody in IBM, whether you're more or less likely to respond to sirolimus, your HLA status, so your genes that code your immune system, to see whether certain genotypes are more likely to respond to treatment or not. So this is all kind of pitched towards trying to really understand that the disease is probably not the same in every single person, and probably there's going to be some treatments out there that some patients respond to and others won't, and it's about being able to try to predict that right up front. So to summarize the medical treatments of myositis, I think hopefully you can see that the approach really depends on your underlying condition. It's quite different from one condition to another. I think as time is going by and we're understanding more of the molecular pathways of these diseases and we're splitting them out from each other, we're starting to develop new targeted therapies that really just pick off the bit of the immune system that is at fault or over-exaggerated in these different forms of myositis. So hopefully we'll get more effective treatments with less side effects in the years to come, as well as in the present. But it's important to remember that we can't just treat the inflammatory aspects of these diseases. We must also partner it with treating the non-immune aspects, the muscle degradation, the muscle regeneration, the well-being, and the bigger picture, the social context of our patients. So what are the take-home messages today? I hope that you've got some, and I hope you haven't fallen asleep yet. So the first step, I think, in any diagnosis is to get a correct diagnosis. And as Chrissy mentioned in her introduction, hopefully that diagnosis or the diagnostic delay with the increased awareness and education of diseases, will dramatically reduce over time. The second step, once you've got the correct diagnosis, is for you to understand your disease. Really, I think that's a very empowering thing. Ask lots of questions, really take a deep dive, research your condition so that you can control the things you can control, the lifestyle and environmental aspects, and the way you respond to having this disease. Don't let it defeat you. You've got to, optimize your condition to give it the best chance you can to fight it. I think it's important for both patients and doctors to remember we need to treat the whole person, not just the physical body, but the psychological impact that these diseases have. In addition, we have to treat both the immune as well as the non-immune aspects. And if you haven't heard me say it before, well, exercise is a vital aspect of treatment for all forms of myositis. It treats everything. And I think nobody should get away with not exercising in IBM. Even if you've never exercised in your life before it, it's never too late to start. So thank you very much for your attention, and I'm really happy to take questions.
Thank you, Dr. Needham. This is Chevelle. So we are going to take questions both from our virtual participants and also our in-room participants. I do see that there are a few questions coming in our virtual platform. So we'll start there, and then I'll circulate the microphone through the room for any in-person questions as well. Okay, our first question. Is it possible to give us some of your opinions on the medication, and I'm sorry, I may pronounce this wrong, sirolimus, and if you see any benefits of this medication and the period it takes to make an effect?
Great question. We've only really just started the trial in Australia, so I can only tell you that we've got 8 patients on treatment, and the first patient is only 12 weeks into therapy, so it's way too early to see any effect yet. So I'm sorry, I can't give you an early view on that yet. We've still got a long way to go. Unfortunately, these trials do take time, especially in slow-moving diseases like IBM that really only change, every few months rather than every week or two. So watch this space, I would say.
Okay, thank you. So the next one isn't a question, but it is a praise. They want to praise you about the section about how to spot bogus science. They said that's very important, and as a fellow scientist, they did want to thank you for that.
I agree. I think it's super important. Yep. Be a bit skeptical about everything and talk to your doctor about it. Always ask.
Okay, the next question is, what is the best way to exercise at home?
Great question. I think it really depends a bit on what you enjoy. I think exercise, it needs to be part of your day-to-day life, and it's got to become part of your routine. And so it has to be something that you find safe and acceptable. So some of my patients even exercise in bed before they get out in the morning, and then they'll exercise again in bed before they get back in with whatever energy they've got left. Some of my patients exercise sitting in chairs, and they use the elastic bands or ankle weights and hand weights in front of the television. Other patients of mine buy stationary bikes because they like riding, or in Australia, a lot of my patients love the water. So we try to get them to either pools that have ramp access. So at home, I think it's really good if you can get an exercise physiologist or physio to sort of at least set you up with some exercises to do on your own chair. So a home, like visiting physio, to come and give you an exercise program that is suitable for you, that you can, I guess, it can become part of your day-to-day routine. And then I'd get that physio back about every 4 to 6 weeks to just step it up a little bit. So you don't want to increase your exercise program every week or two like the young people do at the gym. It's much more a slowly progressive exercise program, increasing either the weight or the number of repetitions that you do very slowly over a very long period of time. So I think getting someone to guide you in how to do that in your own home environment is probably the most successful way that my patients continue to exercise safely at home. I think through COVID, we did do a lot via telehealth. So the physios would dial in and have a look, in the background when it wasn't blurred like mine. So you can see really what the patient environment is like and talk to the patient about what they like to do. Some of my patients like to do exercise that's sort of part of their day-to-day activities and living. So some of my patients love gardening. So the physio will give them exercises that combines that with gardening, and they do that most days. Some of my patients like cleaning, go figure that one, but they give them exercises where they can clean and exercise at the same time. So I think it has to be personalized, and I think it's got to be safe and enjoyable. Those three things are super important, whether you're at home or out and about. I hope that answers your question.
Thank you. The next question, any progress on NAM treatments other than those currently in use?
I think with that really nice review, I think Eve Allenbach and Professor Benveniste are really leading the world with understanding the cellular and molecular pathways in that form of myositis, and understanding the different cytokines that they've identified. I think there's some new trials with some new therapies looking at those specific pathways. They're very early phase studies at the moment, but there's definitely progress in that field. IVIG seems to be very effective in most forms of NAM. So I have to say I use IVIG a lot. And I know increasingly in some parts of the world, they're using it even as the primary treatment, even without steroids. In Australia, we can't access IVIG without trying steroids and methotrexate first, but in other parts of the world, that's not the case. So the short answer is yes, there's lots of progress being done, but the trials are still at a very early phase, probably because it's one of the more new, I think, forms of myositis that's just being really unpicked. It's sort of sitting a bit behind DM in that regard. But NAM is being included in a lot of these JAK inhibitor studies and other studies. So I'd watch this space. I think there are some new therapies very much coming for NAM in the next 5 years or so that will become standard in the next 5 years, hopefully.
Okay, thank you. So I'm going to answer two more virtual questions for our virtual participants, and then I'm going to move to the other side of the room to get some of our in-person questions as well. The next question is, my doctor continues to tell me that there is no treatment for IBM. I am in the process of changing doctors. What medical treatments should I discuss with my new doctor?
Yeah, look, I think that's a tough one, because I would never say there's no treatments, but there's no real proven medical therapy for IBM at the moment. So I guess if you're only focused on medical or immune-based therapies, that what he's saying is, or she's saying, is correct. There's no proven medical therapy that is proven yet to change the natural history of disease. So I don't give my IBM patients corticosteroids or methotrexate or IVIG as a standard at all. But I do actively seek, they're all prescribed exercise, they all see an OT, they are offered a dietitian, they're offered a psychologist. But exercise is really the standard of care in IBM, but looking also at the broader social context and the psychological aspects of living with a disease that doesn't really have an active disease-modifying treatment yet available, understanding that we are working really hard on that. And I think if you're very keen to try therapies, then clinical trials are the way forward in IBM at the moment. And there's a few coming up in IBM in the next few months in America that I'm aware of. So I'd watch this space. So I agree with your doctor, there's no proven medical therapy, but there's lots of things we can do to improve function and quality of life in the meantime while we're waiting for a treatment.
Okay, thank you. The next question, my marker is positive for CD20 and not on your chart, and I don't ever hear it mentioned. Diagnosis was DM. What can I ask about this marker?
So CD20 is a marker that sits on B cells, and B cells are the type. So in your blood, you have white blood cells, red blood cells, and platelets, roughly speaking. The white blood cells we break into T and B cells. So B cells are the ones that produce antibodies, and B cells are the ones that have that CD20 marker on them. So I'm not sure what you mean by your marker is CD20, but certainly rituximab targets the B cells by targeting that cell surface marker. They're anti-CD20 therapy. So it's an antibody that binds to the CD20 and basically marks that cell for killing. So rituximab works exactly like that, by killing off any cell that has a CD20 marker on it, with the hope that you're going to get rid of the cells producing those antibodies that are causing your myositis. And in the case of DM, we know that antibodies are present. We know at least 7 or 8 different antibodies present in DM. And so rituximab for some forms of DM seems to be quite effective. And you partner that with something like IVIG that removes the circulating antibody with the rituximab that kills the cells producing the antibody. Sometimes in some patients that can be a very powerful combination of therapy, but I haven't heard of CD20 being a marker per se of myositis. I think it's more a marker of the B cells that we then target to kill. I'm not sure if that helps.
Okay, thank you. So we're going to take a few questions in the room for our participants as well.
Thank you, Dr. Needham. It's wonderful to see you online. I know that after listening to you, and thank you and Kelly for speaking at the Women with IBM group in March. And just to follow up on that, a couple of the things that you spoke about were the mind and body and how it affects us as we progress in this disease. I wonder if there's a way you can help us as individuals. First of all, are there any studies going on that we can get involved in, or that certain things that we can do as patients to combine the mind-body experience, knowing that the health system and unfortunately the health system you have in Australia and the health system we have in the US is totally different. But sometimes it's very difficult for us to get that bundled necessary treatment. Do you have any ideas or is there any research on that? Because I know from going to other healthcare scenarios, when you went to the healthcare environment with nursing, with light, with et cetera, in rooms, and the healthcare environment is very, very important in healing.
Yeah, look, thanks for that. It is, I think it's a really underdeveloped and under-researched aspect of all chronic diseases, actually. I think doctors, we're very good at medicalizing and focusing on the physical, and, we're not perhaps taught the psychological as much, and it's something that you start to recognize when you look after patients for years, that you realize actually the impact is much bigger than just the physical. And in fact, sometimes the physical is the smaller of the two battles. You're right, our health systems are different. So I'm not quite sure what the situation is in America in terms of being able to access psychology. I think we should together with our patients co-plan a study looking at psychological interventions to see if there's a suite of interventions that would work well in myositis patients. Certainly it's proven in the pain patients. So if you look at the way chronic pain services are set up, it's well proven now that they've got psychologists attached to patients living with chronic pain. And I think we could look at designing studies similar to those sorts of studies to look at what interventions might be the most powerful and acceptable to patients, because there's a whole suite of things psychologists can try. And I have to say, probably different things work for different patients. In Australia, I recommend all my patients see a really good clinical psychologist. And in terms of identifying a good one, because a lot of them would never have heard of myositis, but what you want is a psychologist, I guess, that advertises themselves as helping live better with chronic diseases and disabilities. So ones that advertise or deal a lot with chronic pain would probably be the right sort of psychologist, I think, because they would have all the same techniques of living better with symptoms that never leave you alone, that are always with you. If patients can't afford that, in Australia, it is subsidised for a certain number of visits per year, but not fully subsidised. So there is an out-of-pocket expense even for patients to see a psychologist. then I turn them to online resources. So Headspace is helpful. I point them in the direction of books for mindfulness and books on acceptance commitment therapies and courses that they can do. And the self-driven patients do pursue that. And some people will read books like the Michael J. Fox books, for example, and find that his theory on gratefulness and very inspiring, and they can relate to that. And I learned about I think it's called Perma Plus, PERMA Plus. I've found to be, I just discovered it in the last couple of weeks, but I've introduced a couple of patients if you Google Perma Plus, you can see what this psychological intervention is all about. And it talks about really fulfillment in life, but it talks a lot about the different ways to do that. It's not specific for living with a disease, but it is a really helpful construct to look at kind of where you're at and where you want to be. So I guess that's that. Does that answer your question?
Thank you.
My question is regarding my question is regarding you pronounce it differently, but rapamycin, sirolimus is in phase 3 trial. Is that correct?
Yeah, it's really a phase 3 study. I think in America it's technically a phase 2 study because our definitions are slightly different. So we've labeled it a phase 2b3 study. But basically,
in other words, your trial in Australia is the effectiveness of the drug. Is that,
yep, that's correct.
to sum it up, sort of?
Yeah, so it's a global study. It's being led out of Australia, but we deliberately wanted to include patients from all around the world so that we knew that if it really did have a good signal and it was repeated in all different centers in different countries, then it was a really robust trial and a robust result. So we've deliberately included America, the UK, and Europe in this study, and Australia, to try to make sure that even though we probably do things in slightly different ways, that if the result is going to be positive everywhere, then it should be a treatment that's available to everyone everywhere without having to then repeat the study again.
Okay.
So
my question, that was leading up to this question. There's been a phase 1 safety trial, obviously, or you wouldn't be in the phase you're in, I presume.
No, in fact, there hasn't because it's not a brand new drug. So sirolimus, we've got the benefit that, in fact, it's been around for 20 years. So we probably had some phase 1 studies decades ago before it started being used for renal transplant. So the only question in the IBM or myositis world we had to answer is not if it's safe in humans or what the dose is, which is phase 1 and phase 2. But it's really around, is it efficacious for IBM, which is the phase 3 question. So we actually could leap straight to that. But it started Olivia's study because it was a single center and a smaller number study. He looked at it, so you could call him a phase 2B, I guess. He did it in a smaller number to see if there was a signal for efficacy against the disease.
Okay, I'm going to put you on the spot a little bit, so forgive me. So if the trial in Australia or wherever proves the end points or whatever the effectiveness that it needs to prove, would you as a treating physician prescribe it for IBM patients, knowing
100%.
the risks that are associated with sirolimus?
Yeah, so in every patient, when I prescribe drugs, all drugs have risks. So paracetamol has risks, corticosteroids have risk. But I think you always have to balance the risk of medicines up against the risk of the disease. So I think, and that's really an equation that the patient and the doctor need to talk through, because I think different patients have different risk barometers, if you like. So for some of my patients, they say to me, that their independence is everything to them. Their ability to live at home independent, to wipe their own bottom, walk themselves to and from the bedroom, go for walks with their partner, be able to eat and swallow and go out to eat. For them, that's what quality of life really means. And if they're looking down the barrel of a disease where we know that over the next few years, their ability to do those things independently without requiring help is going to be compromised, then those patients are very prepared to take say a 20% risk of mouth ulcers, leg swelling, kidney or lung problems, knowing that we can monitor for those side effects and nearly all of them are reversible if you stop the drug, whereas the disease risk is a risk that they're not willing to take. They're willing to take that possibility of side effects in a drug, even if it's as high as 20%, for comparing against the 100% risk of the disease getting worse, which they can tell from their own progression of disease. So some of my other patients are so fearful of infections or the potential risk of being more immunosuppressed, that they're very reluctant to take immunosuppression, even for those diseases where these drugs are really proven, because they're just frightened by the potential risk of the drug. And I think it's always important when I talk to patients that the risks of the drugs are potential risks. If you read the leaflet that comes with paracetamol, a lot of people don't hesitate to take a Panadol when they have a headache or a Nurofen. But if you read the potential side effects of paracetamol or Nurofen, it's actually quite horrifying. It's quite scary to read. But that's because we have to tell you everything that can possibly or has ever been linked to these drugs.
Right.
So you're right. There are potential risks with sirolimus, but the reality is they've been using it for about 20 years in kidney transplants. So we're pretty good at knowing all the side effects that probably or could happen to you and monitoring for those. So yeah, it's an equation and it's individual and it's ultimately the patient choice.
That's exactly what I was looking for. Thank you.
Thank you. One of the slides that you had, I felt like I could have spent a half hour looking at it. It was the one about sleep, and I think you called it EDS, something.
Yeah.
Yeah. Okay. So that spoke to me because, yeah, I find that sometimes I'm nodding off when I think I shouldn't be, and I toss it off to I didn't get a good night's sleep last night or to the medications that I'm taking. And I did do a sleep study years ago, and it came back as, no, you really don't need CPAP. So I don't want CPAP. I have interstitial lung disease. I have bronchiectasis. And the idea of putting something like that on me when I know that I cough a lot during the night worries me. So what advice do you have? I mean, I don't want to take sleeping pills, and I know there's melatonin and things like that, but what can we do to help our sleep, to help us do that whole body thing?
Well, that's a really great question. I mean, I start with simple stuff. So I think if people just have the odd really bad night and it's not an all day everything, you're nodding off to sleep all the time, then I think it's about starting simple. So have a really good sleep time routine. So your body really likes routine. So about an hour before you want to go to sleep and you want to kind of get that time pretty consistent most nights. I mean, obviously you make exceptions for Christmas and special dinners, but on average, if you can try to go to bed at about the same time, about an hour before that, start to dim the lights, turn off your LCD screens, change your body temperature, start to listen to some audiobooks or read with a dimmer light in bed, turn your mind off, have a bit of a routine that works for you, and then try switching your light off and trying to get to sleep. If the routine isn't sufficient, then I do tend to suggest melatonin. I think melatonin in some people works brilliantly. I try to make sure that patients don't have things like restless leg syndrome or iron deficiency or other things that might be confounding the difficulty getting off to sleep or staying asleep. I'd get them to look at their mattress, make sure that the mattress is comfortable, make sure that they're able to turn over in bed at night. And if they're having trouble and they're having to wake up to turn over, suggesting things like satin sheets and satin pajamas so you can slip around the bed a little bit easier. or rails so that you can pull yourself around a little bit easier without really having to wake up to do these things is helpful. I tend to not use the sleeping tablets like the temazepam or the benzodiazepines very much because I don't like them because they're a bit addictive. They're related to falls. So I tend to avoid them in my neuromuscular patients if I absolutely can. And my preference would be, even if I had to start a drug therapy, would be to start, there's an antidepressant with the drug name mirtazapine. I don't know what the drug name would be in America, but I use that a little bit because often sleep deprivation can be associated with a mood disturbance as well. And mirtazapine is very sedative it's one of its side effects as an antidepressant. And so some patients, but it's not addictive. It doesn't seem to be related to falls. And it's at the lowest doses, it's most sedative. So it's most antidepressant at the high dose, but at the lowest dose, half a tablet at night, it works quite well for some patients to really help their sleep. So if I have to go to medical therapy, that would be my sort of
And what was the name of that again?
It's something called mirtazapine, mirtazapine. So that's one that I prescribe a bit for some of my patients that have trouble sleeping, where it's not bad enough that the sleep study doesn't seem to think they need NIV. And some patients just use that intermittently. They don't use it necessarily every night. It's just if they have a couple of bad nights in a row and they really need a good sleep, then that can work quite well for some people. So again, it is a bit of a personalized approach. What works for one doesn't always work for another. But I'm a big believer in starting simple, changing lifestyle things, getting your environment right, getting your light right. The brain is very light, dark sensitive. So you want really pitch black. You don't want lights around because that really disturbs your brain's ability to produce melatonin. It needs darkness for that. And then I sort of get a bit more progressive with the sleep after that. Does that make sense?
Yeah, it does. And there are a couple of things there that I know I'm going to change right now. Ooh, satin sheets. Woo.
Hi, Dr. Merrill. My name is Merrill. I was newly diagnosed in May, right? So I'm still in the process to know like what type of myositis do I have. The thing is that, or my question is, can you diagnose with only the blood test? And the reason why I'm asking is that I already on my second rheumatologist, and he has a total different opinion from the first one. Muscle biopsy came out with no inflammation. MRI showed no inflammation. However, the blood test is really all over the place. High inflammatory markers are super high. The myositis panel, the SRP antibody, it's like super high, very elevated. And I do have symptoms and everything. So this first doctor was gonna already put me on treatment, prednisone and methotrexate. I can't pronounce that. But then this other rheumatologist is like, I'm not gonna give you any treatment right now because you are like, you move. So that's long story short, what he said. So he just gave me a follow-up appointment for December. So I guess I'm just like, what should be my best next move to like find out, first of all, what type of myositis do I have to like, it seems, well, what I have learned here in these 2 days, it seems that it's going to be NM because of the SRP antibody. But yeah, I would like to like hear your thoughts on it. And if I can like follow up with you online or something, that would be great. I would do it. Thank you.
Look, they're great questions. And I think you're quite right. So when you're newly diagnosed, it is important to make sure you have the correct diagnosis. And it is always good to seek multiple opinions, but it's always hard, I think, if the opinions are diametrically opposite. So I think the first thing is it does depend a lot on the antibody. So not all antibodies are equal, and it depends a bit on the lab that measured it and what technique they use to measure it. But that being said, SRP is in our lab at least, is a pretty high performing antibody. So what I mean by that is if you have a high titer in a clinical context that makes sense, I believe it. And in fact, I wouldn't expect to see inflammation on your biopsy. There might have only been 1 or 2 regenerating fibers or a necrotic fiber, and that would be enough actually. So for you, with that antibody result and symptoms, I don't think it's reasonable to wait till you're not walking to start to treat you. So I think you'll lose too much muscle and it'll be very hard to come back from that. I'm a big believer that the quicker you nip it in the bud and the more muscle you've still got left, the better your long-term outcome is going to be. So I would do this by getting your muscle biopsy reviewed by some experts in the field. And there are plenty at Orlando. So you've got, I think, direct access to some fantastic, wonderful groups and teams and people there. I know Hopkins has a great group. There's lots in America. You're full of experts, but the Myositis Association has some amazing docs on their scientific committee, and a lot of them are there. So I would grab any of those guys. I don't know exactly who's there, but and I would ask them exactly what you asked me. Get multiple opinions while you're there. But what I would do for you if you had contacted me from Australia or whatever is I would get your slides and I would review your whole clinical picture. So it's about the company that it keeps. So patients are a whole picture. They're not just one antibody result or one CK measurement. It's about everything. It's about how it started, when it started, how it's changed over time, what effect it's having on your life. Then I would look at your physical exam because that's quite a subjective thing, me versus you. Then I often do as a neurologist, I love EMG. So when your rheumatologist sort of presses on you and tries to work out if you're weak, the EMG is like it's an objective examination. So we can stick a needle in your muscle and we can hear if there's a problem. Much more sensitively and objectively than just pushing on your muscle. And so I would maybe, I don't know your system well enough in America to know if you can pursue an EMG if you haven't had one. I would get your muscle biopsy reviewed by a team that are used to looking at antibodies in muscle biopsies in myositis, because again, not every pathologist is a muscle pathologist. And then finally, if those things haven't resolved the difficulty between your first 2 rheumatologists, find a third one who's an expert in myositis and go to them and see where the overall opinion lies. But SRP is a high performing antibody. If you have a high titer, you've got symptoms, I think it would be tricky not to even give you a trial of treatment for a period of time to see if it resolved your symptoms and made you function better and feel better. But it's very hard. I can't give you personal advice in this sort of context, but that would be an approach, perhaps. Sorry, I speak with my hands and I know they're blurry for you, so sorry.
Hi, Dr. Needham. So we have time for one more question, and then we will have to wrap up the session.
Thank you very much. Definitely appreciate your overview. You talked a little bit about the impact of the disease process on the mitochondria. My question really revolves around the fatigue and the time it takes to recover after exercise. Is there a ratio in terms of the amount of impact on the mitochondria versus the muscle wasting and just the impact of exercise itself in terms of the tiredness of fatigue that comes with the disease?
Yeah, look, that is a great question. And I would love to look at that in more detail because I have some patients that exercise 45 minutes a day, no problem. And I have other patients that do 10 minutes and that's them for the day done. And I've never really seen any study that's looked to correlate the degree of mitochondrial changes seen on biopsy versus that exercise intolerance. What I will say is, though, I do treat patients with primary mitochondrial disease, and the treatment for them is also exercise, but it's a very slowly progressive program. So you might even start with 2 or 3 minutes, and it is around the consistency. So if you can do that at least 5 days a week, if you can do even 3 minutes for that for 4 to 6 weeks, then you'd go up maybe to 4 minutes, but you wouldn't go to 6, right? You don't double it, because with mitochondrial disease, you've just got to very slowly churn away at getting your proportions of good versus not functioning very well mitochondria to change in favor of more good and less bad. So I think it's a really tricky one. I don't think anyone's really looked at it. I think it makes theoretical sense to me, given how similar some of my IBM patients are to some of my primary mitochondrial patients with regards to that exercise intolerance and early fatigability. But I think the answer at the moment, even for mitochondrial patients, remains pretty much the same. So I do try coenzyme Q10 in those patients at a dose of around 150 milligrams twice a day. It might be very expensive. I don't know. I've never done a trial, and I say to my patients to try it for up to 3 months. And if you can identify a function that you struggle doing at the beginning and you're doing it much more easily at the end of that 3 months, then stick on the coenzyme Q10. If you think it's done absolutely nothing, come off it, because it is moderately expensive. And I combine that though with exercise, and a very slowly progressive exercise, and just set your goals realistic for you at the beginning and just slowly churn away, so that over a year or two, hopefully you're getting close to 20 or 30 minutes most days. And the other analogy I often give my patients is, imagine you have a cup of energy to use every single day. So you wake up in the morning and your cup's as full as it's going to get. On a day where you've got lots to do, you've got to get out in the garden and you've got errands to run and you're going to go out for dinner with friends that night, that might not be your morning to get up and exercise. But on a day where you haven't got a lot on, you might get up and do a little bit of exercise in the morning, then keep some energy to do your day-to-day tasks. And with whatever energy you've got left in that cup in the evening, just before you go to bed or in bed, so that it's really safe, do a little bit more exercise, use up that whole cup of energy, and that might help you sleep better too. So I think exercise, you don't want to do it to the exclusion of everything else in life. Life is a balance, and you have to keep that cup of energy, especially when you're really intolerant of and getting quite exhausted. And I guess recharging the battery during the day. So an afternoon nap after lunch, keep it short though, or it will affect your night sleep. So keep it under an hour. But a lie down after lunch can sometimes just give you a little bit more oomph in the afternoon.